Good evening, everyone. I'm Dr. Sandeep Sharma, your pediatric faculty for super specialty at PrepLadder SS, and it's my privilege to connect with you, all of you here. Some of you requested me just a few minutes back in my group saying, "Sir, aaj kya padhayenge?" And "Sir, can you take more sessions?" See, there is never an end to the sessions, but jo hai, there is a movie, Ye Jawani Hai Diwani. It's an old movie now, but there was a dialogue कि जहाँ है उसी का मजा लेते हैं, right? कुछ ना कुछ तो छूटेगा. So I think the same is applicable in our preparation also. Whatever we are doing, we always have that FOMO that we should be doing something else is getting left behind. But the aim should be that whatever we do, let's do it the best we can. So keeping that in mind, there are 4 LRRs that have been planned, and if the time permits, and if all of you agree, we can plan some more similar sessions in the coming days as well. So as promised to all of you, last session, I had focused on some controversial areas, some updates in obesity, and I had focused on LRR points related to malnutrition. Here, my focus is going to be inborn errors of metabolism. So yes, there will be some miscellaneous things I will be discussing, but my focus will remain on inborn error of metabolism. Inborn error of metabolism is always a gray zone for many of us, and many students are not very confident when they are answering questions on this. So that is the area, that is the place where I'm going to focus on. The time I spend on a topic will be related to its importance, and of course, I will not be going into too much of technical cycles, except phenylketonuria and related disorders, where I will go into details. And I will also be sharing with you what were the recently asked questions asked on the topics. So let us start with inborn error of metabolism summary. Let's try to cover as much ground as possible in the next 1 hour or so from super specialty point of view. The first thing is phenylalanine metabolism defects. Now, phenylalanine is a versatile amino acid, and phenylalanine is involved in, it's an essential amino acid. It comes in the diet, and this phenylalanine is then converted into multiple other amino acids, keto acids, derivatives, and this is the one which is responsible for forming our dopamine and other catecholamines. This is the precursor for our melanin, the pigment in our body. It is also the precursor for many neurotransmitters in the body. Now we know that body never takes its chances, and there are salvage pathways available for other intermediates as well. But whenever there is a problem in phenylalanine metabolism, eventually brain or skin or liver or a combination of these will always be affected. And so together, these conditions are called as phenylalanine metabolism defects. What are the conditions which are included? The common conditions which are included in this, they include number 1, phenylketonuria. We have the 2 varieties of phenylketonuria. We have the classic phenylketonuria as well as the variant of phenylketonuria, right? So there are basically 2 subtypes here. Secondly, we have the Tyrosinemias, which are included in this category from exam perspective. Now, Tyrosinemias can be of 3 varieties. We have type 1, type 2, and type 3. The third variant of this is Alkaptonuria. And the fourth variant of this is albinism and related disorders. Then there is a minor group of disorders, sometimes asked in the exam, like Hawkinsonuria, etc. Those are more of a one-liner based thing. So we'll not be going into the details of those because we have very limited time available for the discussion. I hope I'm audible and visible to all of you. I'm not looking at the screen. I'm just opening to see myself in the phone. If I am visible, yes, I'm visible. So I'm visible. So in between, I'll be taking a break and I'll be answering all your queries in case you have any. So let us start with the phenylalanine metabolism defect. First, we need to understand the cycle which operates in these patients. So this is the phenylalanine metabolism cycle. For those who are thinking, sir, itni jaldi kaise likhenge? Based upon your feedback, after the session is over, annotated PDF of this session will be made available in the comment section later tonight. Okay, so what it means is you need not scurry through, keep listening, keep understanding, and if there is a cycle kind of a thing, you can always jot it down later. Okay, so phenylalanine is first of all converted into, I'll be marking as I write. So it is first converted into an amino acid called as tyrosine by an enzyme called as phenylalanine hydroxylase. This is also called as PAH enzyme. This is PAH enzyme. Then it is converted into, you can see in the photograph, it is converted into 4-hydroxyphenyl pyruvate by the aminotransferase enzyme. Then you have 4-hydroxyphenyl pyruvate dioxygenase, also called as 4-HPPD. 4-HPPD is the other name of this enzyme. Then you have 2,5-dihydroxyphenyl pyruvate forming. Then we have homogentisic acid forming. Then homogentisic acid oxidase acts on it. First, we have mallyl, then we have fumaryl acetoacetate, and eventually it is broken down into fumarate plus acetoacetate. There is another pathway where tyrosine is converted into dopamine and melanin, and the enzymes involved include tyrosine hydroxylase as well as tyrosinase. So these are the four, this is the entire phenylalanine metabolism cycle. First thing, which is asked in super specialty exam, identify the enzyme deficiency for a particular metabolic disorder. So let us label it in this photograph itself. I'm trying to label it here only, that in case there is a deficiency of phenylalanine hydroxylase, the patient develops a disorder called as phenylketonuria. So what is the most common enzyme deficiency causing phenylketonuria? Your answer will be phenylalanine hydroxylase enzyme. Secondly, we have tyrosine aminotransferase enzyme. If this enzyme is deficient, the patient develops a disease called as tyrosinemia. But many types of tyrosinemias are there. So Tyrosinemia type 2 is produced whenever there is deficiency of tyrosine aminotransferase. Then if there is deficiency of this enzyme, 4-HPPD, hydroxyphenyl pyruvate dioxygenase, the disease so produced is called as Tyrosinemia type 3. Then if there is a deficiency of homogentisic acid oxidase enzyme, the defect so arising is called as Alkaptonuria. If there is a deficiency of fumaryl acetoacetate hydrolase, the disease so arising is called as Tyrosinemia type 1. And finally, if there is deficiency of tyrosinase or tyrosinase with tyrosine hydroxylase enzyme, the disease so produced is called as albinism. So this is the step which will be involved in albinism. So you can see I have highlighted here what are the corresponding enzymes. So when you get the PDF, even if you have read before, go through it rapidly so that you are ready from exam perspective. In SS exam, not every question will be bouncer. There will at least be 20 to 25% questions which are one-liner or simple thing. I'll give you an example. Question will come, and it is a question from 2019 NEET super specialty. The question will be, a 6-week-old male infant is found to have hypopigmentation in the form of blue hair, blue eyes, blonde hair, and fair skin. The child also has microcephaly, seizures, and dystonia. Ferric chloride test is positive. What is the most common enzyme deficiency? Now, it should be clear in your mind that this is a patient who has hypopigmentation. Hypopigmentation with CNS involvement is phenylketonuria. Hypopigmentation in the absence of CNS involvement is albinism. So you know the diagnosis is phenylketonuria. And phenylketonuria, what is the most common enzyme deficiency? You need to know precisely phenylalanine hydroxylase. So such simple questions are also asked in your exam. And this flowchart will help you in identifying such topics. With this background, with this understanding of the pathophysiology, let us go into individual disorders. And I will be covering a lot of ground. So what I have done this time is I have kept only empty slides. Each disorder I pick up only relevant points in a very unique manner so you can revise it better. So I'm giving the heading. The first disorder that we are going to take up is phenylketonuria, PKU, phenylketonuria. Now, phenylketonuria, what is the type of inheritance in these patients? What is the type of inheritance? Just a minute. What is the type of inheritance? Most patients of phenylketonuria, they are having autosomal recessive inheritance. What are the enzyme deficiencies? The most common enzyme deficiency, which is found in about 95% of the patients, is deficiency of phenylalanine hydroxylase. So there is a deficiency of the enzyme phenylalanine hydroxylase, also written as PAH. And the deficiency of this enzyme produces the disease, what you call as classic phenylketonuria. So classic PKU is deficiency of phenylalanine hydroxylase. Then we have the other rare variants. Rare variants are due to deficiency of a cofactor called as tetrahydrobiopterin reductase. Tetrahydrobiopterin. Tetrahydrobiopterin is a cofactor for phenylalanine hydroxylase. And if there is deficiency of this substance, then also the patient develops phenylketonuria. Tetrahydrobiopterin is written as BH4. So BH4 deficiency can also produce it. This category has other subtypes based upon what enzyme deficiency is involved in producing tetrahydrobiopterin deficiency. For example, you have dihydropteridine reductase. You have various degrees of fumaryl, manolyl coenzyme hydroxylases deficiencies, and so on. So what you need to remember is the most important one is this. Secondly, it can also occur due to tetrahydrobiopterin deficiency. Nelson sometimes uses the word non-phenylketonuria hyperphenylalaninemia as well, whereas other textbooks call them as variants of phenylketonuria, right? So these are the enzyme deficiencies. Now, what exactly is happening in the patient? Let us try to understand that. So for that purpose, I will try to write a flow chart over here. I'll make a flow chart kind of a thing. I'll make it here so that it is easy for you to follow. So what happens in a patient of phenylketonuria is that phenylalanine is the amino acid which comes from the gut. This normally gets converted into tyrosine. This reaction is catalyzed by phenylalanine hydroxylase, the enzyme. It is also catalyzed by tetrahydrobiopterin. So BH4 is the cofactor. Now imagine that there is deficiency of either phenylalanine hydroxylase or tetrahydrobiopterin. So there will be a block happening. If a block happens, tyrosine will not form, and tyrosine will become an essential amino acid. Normally, tyrosine is not an essential amino acid. Now it becomes an essential amino acid. Now, tyrosine will not form. It means that the downstream metabolites like melanin will also not form. And when melanin will not form, the patient will develop the first set of features. The child will develop hypopigmentation. So the first group of disorders which arise because of this enzyme block is hypopigmentation. The child will be having fair skin, the child will have blue iris, and the child will have blonde hair. So hypopigmentation will appear. And it is not only hypopigmentation. These children sometimes will also have increased risk of developing seborrheic dermatitis. So seborrhea or seborrheic dermatitis like rash will be common in these patients. So dandruff-like rash will also be more prevalent. At the same time, I'm writing in this format so it is easy for you to write. It takes less time and MCQs will also be solved. I will tell you how. NEET SS question is also hidden in this. So phenylalanine not forming tyrosine, melanin will not form. That is hypopigmentation, first thing. Now, what diet is giving you phenylalanine? What will happen to the excess phenylalanine? Two things will happen to this phenylalanine. First of all, phenylalanine, when it is in excess, it will compete with LNAs. What is LNAA? Large neutral amino acids like tryptophan, like branched-chain amino acid. They all have a similar transport mechanism, and it will compete with LNAs for entry into blood-brain barrier. So what will happen is, because there is excess of phenylalanine, so now it will preferably enter into the blood-brain barrier, producing CNS toxicity. So the second phenomena will occur, that is CNS toxicity. Why CNS toxicity happens? Other LNAs are unable to enter into the brain. Instead, excess phenylalanine reaches, which creates a disbalance in the brain. The neurotransmitter balance in the brain gets disturbed, leading to CNS toxicity. So patient will develop features like microcephaly. There will be seizures. There will be developmental delay, later on progressing to low IQ. And there will be spasticity, along with dystonias. Dystonias will indicate extrapyramidal involvement. Spasticity will indicate pyramidal tract involvement. And microcephaly, developmental delay, seizures will indicate your gray matter, that is cortical involvement. So every part of brain will get affected due to excess phenylalanine. And third thing, phenylalanine body will try to fight, right? So the liver will try to degrade phenylalanine. So some of the excess phenylalanine in the blood will be converted into phenylketones. And these phenylketones are water soluble and they are excreted in urine. Three types of phenylketones are known: phenylactate, phenylpyruvate, and phenylacetate. It is the metabolite known as phenylacetate that gets excreted in urine and has a particular smell. We call it as musty or mousy urine odor. So it will produce a musty or mousy urine odor. And this, my dear friends, is the third feature of phenylketonuria. Right? Now listen to me carefully. What are the three set of clinical features? Hypopigmentation, and you can describe. Second, CNS toxicity, and you can describe. Third, abnormal urine odor. What kind of urine odor? Musty or mousy urine odor. What produces it? Phenylacetate produces it. I'm putting a small Q here. It's a past MCQ point. Second point, degree of CNS damage depends upon what? It does not depend upon the metabolite. It does not depend upon tyrosine. It depends upon serum phenylalanine itself. So degree of CNS damage correlates with blood levels of phenylalanine. Higher the phenylalanine level, more will be the degree of neurotoxicity in the patient. If you remember the flow chart like this, it is very easy, and you're also able to confidently answer questions arising from this. And because serum phenylalanine decides the degree of severity of phenylketonuria, so there is a classification that we follow. The classification of phenylketonuria says, what are the types of phenylketonuria? They are based upon, on one side, they are based upon the serum phenylalanine levels. So serum phenylalanine levels. Normal value, I'm writing on the side, the normal value in you and me, it is always less than 2 milligram per deciliter. So when the serum phenylalanine is 2 to 6 milligram per deciliter, we say the patient is having mild phenylketonuria. What is moderate phenylketonuria? If it is 6 to 10. What is severe phenylketonuria? If it is 10 to 20 and above. There is a variation of this where the cutoff is 6, 10, and 20, right? There is another variation of this. So this is the more popular variation, the more popular classification, which is sometimes followed. But again, in an Indian system, many times we do not follow this. What this classification basically is telling you is that the degree of phenylketonuria, that is degree of CNS damage, directly depends upon the serum phenylalanine levels. And the normal value is always less than 2 milligram per deciliter. So remember that what is the now we have the MCQ point INI super specialty exam. What is the target serum phenylalanine levels? Target serum phenylalanine levels during therapy. What level you should be targeting? You need to understand that level normal to kabhi nahi hoga. It will never happen. So the target serum phenylalanine levels during therapy should be keep the levels between 2 to 6 milligram per deciliter. If you keep it in this group, the patient is going to do quite well. And if they say when to treat, if the level exceeds 6 to 10 milligram per deciliter, that is the time where you will be considering treatment in the patient, right? So these are the types of phenylketonuria. Let us move towards the investigation part. What are the investigations that you are going to do? Now, the investigations, first of all, we do a test called as Guthrie's test. So there are older tests which are available. Which include Guthrie's test. In fact, there is a very interesting thing. Guthrie's test was the first metabolic test which was devised for any metabolic disorder. So Guthrie test is of historical importance. You can also do a urinary ferric chloride test in the patient. So ferric chloride test can also be done, and we used to find green discoloration indicating phenylketonuria. But now these days we follow for screening purpose. The screening test of choice is we take the DBS sample. You know what is DBS sample, dried blood spot sample. I'm going a bit fast because I know that most of you are preparing for the exam, sitting in the exam. So dried blood spot, and we do TMS, tender mass spectrometry on this, and we check for the elevated levels of phenylalanine. These days, PAH genetic analysis basis is also available, but generally for screening purpose, it is good enough. And the gold standard for diagnosis will always be elevated levels of serum phenylalanine. Now, what is the treatment that you are going to give in the patient? Treatment. Multiple parts. First of all, dietary control. So dietary control, two types. You will put the patient on low protein diet. However, it is not always possible, and it will affect the growth of the child as well. Second thing, you will put the patient on special diets, which are phenylalanine restricted. There are special phenylalanine restricted diets which are available, but obviously only in a rich household it is possible. A poor person or in a country like India with socioeconomic barriers, it is not always possible to follow this diet. Secondly, you can try, there are some approved therapies, some trial therapies. You can give a trial of oral LNAA supplements. These supplements not only compete with phenylalanine and decrease its absorption from the gut, but they also counteract neurotoxicity. However, Nelson says that more data is, although initial studies are promising, but more data is needed before it can be FDA approved. Third is synthetic derivatives of tetrahydrobiopterin, right? Remember that cofactor. So there is a drug called as sapropterin hydrochloride. Sapropterin hydrochloride is a drug which is a derivative of tetrahydrobiopterin. It is FDA approved for use in patients with phenylketonuria. It has been shown to augment phenylalanine hydroxylase activity if it is low. And lastly, you can consider other agents like there is another agent called as phenylalanine ammonia lyase, but that is not approved for use in children. That is approved for use in adults. So these are some of the therapies which are available for phenylketonuria. Remember, the outcome is not poor. And I am going to tell you a very, very interesting thing here. So when you and me were born, somebody is posting, I've just opened it, cover maximum syllabus. Dear friends, this is not for syllabus completion. We are preparing for super specialty, and pediatrics, you know, it is vast. So there's a last resort revision covering those topics and one-liners which might be handy close to the exam, right? So this is more of a fighting chance. It is not a syllabus completion. For syllabus completion, you need to do the regular videos properly. So, and about, yes, MSUD. Dr. Saifer, I will be taking up MSUD topic. So don't worry, I will discuss MSUD also. So listen to the funda, very interesting funda, and it will come handy to you. When you and me were born, our skin was more fair. As our age increased, we became more brown. Our pigmentation actually increases with age, right? In phenylketonuria, reverse happens. When the child is born, he's still having some pigmentation. Some derivatives derived from the mother, some melanin has formed in utero. As age increases, now when the child has to make the convert tyrosine and then make melanin himself, he cannot do that. And so pigmentation improves with age. In a phenylketonuria patient, child becomes fairer as the age increases. So initially the parents are very happy. Bacha gora ho raha hai. The child is becoming fair. But at what cost? Brain. More hypopigmentation, more phenylalanine, and more brain damage in the patient. If you have two phenylketonuria patients, one is fairer than the other, which one has more CNS damage? The one who is fairer also has more CNS damage in phenylketonuria, right? Think about it, and it's a very useful thing you find in clinics, not given in Nelson, not given in manuals, right? But it's a part of the literature, and you might get, they'll never know about the examiners, what they might put in the exam. So this is the first disease that that is phenylketonuria. Let's move further. Let's move further, and we'll talk about Dr. Cypher. Refsum disease also I will cover today. Don't worry, stay with me. Second topic. Now we can pick up the speed. Second topic, we have tyrosinemias. What are the three types of tyrosinemias? I have told you, I'm giving the heading Tyrosinemias. Tyrosinemias, what are the three varieties? I have already told you. Go back and see this photograph. You can see that we have Tyrosinemia type 1, which involves fumaryl acetoacetate hydrolase enzyme. Secondly, it involves Tyrosinemia type 2, that is tyrosine aminotransferase. And third is Tyrosinemia type 3, where it is 4-hydroxy phenylpyruvate dioxygenase. Now, how to distinguish between them and what are the key points that you will remember regarding regarding tyrosinemia? So first thing I would write about tyrosinemia is all the varieties are autosomal recessive. So they all show autosomal recessive inheritance. Now, how to remember? I'm writing it like this. So three variants, the three types, we have type 1, type 2, and type 3. Type 1 is the most common variety, and this is the variety which is also called as classic tyrosinemia. It is also called as hepatorenal. So type 1 is the one which is also called as hepatorenal tyrosinemia because it involves kidneys and the liver always. So type 2 is also called as Richner-Hanhart syndrome. Richner-Hanhart syndrome. It is also called as oculocutaneous tyrosinemia because there is always ocular involvement and skin involvement in the patient. And type 3 generally does not have its separate name. Now let us talk about one by one. In case of type 1 variety, the enzyme which is deficient, in case of type 1, it is the enzyme which is FAH hydrolase deficiency. The full form I have already written in the previous slides. In case of type 2, it will be tyrosine aminotransferase deficiency. Tyrosine aminotransferase deficiency. And in case of type 3, you have the 4-HPPD deficiency that you will find in the patient. Now, let us first look at type 1 disease. Type 1 disease is the prevalent one. It is also the severe form. In type 1, there is a triad of organ involvement which is seen. Triad of organ involvement means 3 organs which are commonly involved. And what are these organs which are involved? The patient is having liver involvement, the patient is having renal involvement, and the patient is having peripheral neuropathy, that is peripheral nerve involvement. So 3 organs which are commonly involved is called as the clinical triad of hepatorenal tyrosinemia. This is your MCQ point. Old MCQ, but you can add to the notes. What are the 3 organ systems which are often involved? So I will come back to this slide. So let us continue the discussion here. So in these patients, first of all, what is the age of presentation? The age of presentation in the patient is generally in infancy. It is between 2 to 8 months. So anytime between 2 to 8 months, the patient can present. What are the features? First of all, patient will have hepatic involvement or liver involvement. Liver involvement will be in the form of acute hepatic crisis in the form of hypoglycemia. So the child will have hypoglycemia, child will have jaundice, child will have vomiting, and there will be development of ascites in the patient. And later, it will progress to cirrhosis. And eventually, if many of these patients will develop hepatocellular carcinoma. So hepatocellular carcinoma is a malignancy which can occur in these patients. One of the end point of these patients, about 1 decade later, these patients develop hepatocellular carcinoma. And that is why routine, regular AFP monitoring is indicated in these patients. So in which phenylalanine metabolism disorder, regular AFP monitoring is needed? The answer will be type 1 tyrosinemia because hepatocellular carcinoma can develop. Secondly, renal involvement. Renal involvement will occur in the form of damage to the Proximal tubules. So these patients will have proximal tubule damage producing Fanconi syndrome. You all know what is Fanconi syndrome. There will be metabolic acidosis, there will be rickets, there will be bicarbonate urea, phosphate urea, amino acid urea, etc. So Fanconi syndrome like presentation can occur. And thirdly, peripheral neuropathy involvement. Due to involvement of peripheral neuropathy, two things will happen. It is not tingling, numbness, etc. It is pain and abnormal body postures which will occur due to peripheral neuropathy involvement in the patient. And many times these patients can have a acute porphyria-like presentation also. They can have an acute porphyria-like presentation as well. So these are the three organ systems and the feature. And a very unique thing happens in these patients. Whenever you check their urine, the urine will have a boiled cabbage odor. Urine will have boiled cabbage odor. What was the urine smell in phenylketonuria? It was musty or mousy. Here it is boiled cabbage odor, and the cause of toxicity in the patient. All this liver damage, renal damage, and nerve damage is happening because of a metabolite called as succinyl acetone. Succinyl acetone is the culprit. The other metabolites are also responsible, but the most important cause of toxicity is raised levels of succinyl acetone in the patient. Okay, so this is your type 1 tyrosinemia. I've gone into detail because this is the one which is also more commonly asked in the exam. Let us go to the other part. Then we have type 2 tyrosinemia, oculocutaneous tyrosinemia. These patients will have oculocutaneous, as the name itself is saying. So two features will occur. First of all, these patients will have ocular feature. What ocular feature will happen? They will have bilateral herpetiform, herpes-like. Herpetiform means herpes-like corneal ulcer. So bilateral herpetiform corneal ulcers, which will occur recurrently in the patient, and these will always be present. And secondly, cutaneous. Cutaneous, there will be development of painful palmoplantar on palms and plantar area. Keratosis, also called as keratoderma, will occur. It will be non-itchy, but it will be painful. And plus minus about 50% patients will be having low IQ as well. So this will be the presentation, but no increased risk of hepatic malignancy. And then we have type 3 tyrosinemia. These patients will have seizures, ataxia, they have low IQ, and they have self-mutilation behavior. I hope you all know that self-mutilation behavior is described in Leach-Nyhan syndrome. But there is a third variety called as type 3 tyrosinemia. There also self-mutilation behavior can occur. And in one of the PG entrance exam, this has been asked. In one of the PG entrance exam, not in the super specialty exam, right? So this is the clinical picture of the types of tyrosinemias. And in case of tyrosinemia type 1, we have a specific therapy which is available. So in case of these patients, the drug of choice in the patient is nitisinone. Nitisinone is an inhibitor of 4-HPPD inhibitor. Nitisinone is not effective in the other varieties much, but it is effective in these patients. And nitisinone, the earlier you start, the better it is. A high dose nitisinone is available. And later, if the patient presents late or there is no response, liver transplant will eventually be needed in the child. Eventually, liver transplantation will be needed in the child, right? So we are done with the second category. That is tyrosinemias, right? Inside out we have discussed. Let us go to the third part. The third one is easy one. And then I change the topic. I know many of you are waiting for these other metabolic syndromes, metabolic disorders. I will come to that as well. So alkaptonuria. What is alkaptonuria? It is a relatively benign metabolic disorder involving phenylalanine metabolism. About alkaptonuria, there are a few points to note. It is the first inborn error of metabolism to be diagnosed. The first one to be diagnosed, the first one for which a test was devised was Guthrie test for phenylketonuria. But the first IEM to be identified that it is a metabolic disorder, there was a person called as Garrod who had identified it. That is alkaptonuria. Alkaptonuria also shows what kind of inheritance? It shows autosomal recessive inheritance. What is the enzyme deficiency? These patients will be having homogentisate oxidase deficiency. Homogentisate oxidase is also known as homogentisic acid 1,2-dioxygenase deficiency. So these are the two names of the same condition, so don't get confused. In Alkaptonuria, 4-HPPD cannot be broken down. And so there is accumulation of these metabolites. They are pigment forming. On exposure to air or in the tissues, they get converted into a black polymerized pigment. This pigment gives black discoloration to the tissue. That is what you call as Alkaptonuria. Black eyes, kali kali aankhein is Alkaptonuria, neeli aankhein is albinism or Phenylketonuria, right? So what are the clinical features of Alkaptonuria? The first symptom in the patient, first symptom or first sign, you can say, first sign or symptom is mother will notice that the urine become black on exposure to air. What it means is when the urine is passed, it is not black. That way you can distinguish it from the cola-colored urine or tea-colored urine in gross hematuria. That is black from the beginning. These patients, when they pass, it is normal color, faint yellow straw-colored urine. But as you keep it for some time, or if the nappies drenched with the urine are kept for some time, on exposure to air, the urine becomes black and the nappies become black. That is the first sign. And later on, the pigment starts getting deposited in the tissues. And in the childhood, you have a condition developing in the child called as ochronosis. What is ochronosis? It refers to black pigmentation. 3 tissues are deformed, visually deformed because of black discoloration. Black eyes, sclera. Black nose, nasal tip. And black pinna, that is external ear. So it is visually deformed. And later on, this pigment will now start getting accumulated in the joints of the spine as well as in the larger joints like hip, knee, and ankle. And it will cause ochronotic arthritis. Ochronotic arthritis resembles osteoarthritis. And just like osteoarthritis, it is also a painful, debilitating, deforming arthritis. And what are the other manifestations? Some patients can develop back pain. Why back pain? Because patients can have calcification. It promotes calcification also of the intervertebral disc. Some patients can develop renal stones. And my dear friends, here comes your INI Super Speciality 2022 Mid-Year General Pediatric MCQ. What is the major cause of morbidity and mortality in a patient of phenylketonuria? So, taza question, relatively taza question. Mortality and morbidity occurs because of calcification of the heart valves. So, valves like mitral as well as aortic valve get calcified. And so stenosis, mitral stenosis, calcified mitral stenosis, calcified aortic stenosis can occur. And also these patients have increased risk of MI. Myocardial infarction risk is increased. The vessels tend to become stiff. Even the muscular arteries, the coronary arteries tend to calcify in the patient. So what is the investigation that you will be doing? Yes, investigation of choice in these patients will also be TMS, tender mass spectrometry can be done for screening purpose. And these patients, drug of choice is also nitisinone. Here, nitisinone is given in lower doses compared to what you give in tyrosinemia. And this is one condition where the CNS involvement is not that significant. So these patients can lead a relatively normal life compared to other ones, right? So this is the first category of disorders that is called as phenylalanine metabolism defects. About albinism, remember, albinism has its own world where you have, but the common thing about albinism will be generally in those patients, the IQ is not affected. So if there is a hypopigmented, completely depigmented person, and IQ is normal, he or she is a doctor, you will think of albinism in the patient. And albinism has multiple subtypes, it has syndromes, it has associations, Hermansky-Pudlak, oculocutaneous albinism, then ocular albinism alone, subtypes, Waardenburg syndrome, they will all come over there. So I hope you have gone through that. In case time permits, when you are revising, go through those topics also. Let us move further. So our big group of metabolic disorders is done. Let us move towards the second group of metabolic disorder. As many of you have been asking me, देखो इसका video I had put up in the app also, but I will be discussing briefly over here. The disorders are called as peroxisomal disorders. Peroxisomal disorders. Let us do a rapid fire, quick review of the topic. Now, I have not been seeing your messages. I hope you have not put any controversial messages or bad words for me. So let me have a look. My internet is also playing games with me. So where is the chat box? Arvind Hipargi, MI is the cause of death in Alkaptonuria in many patients, given in Nelson. Calcification occurs there. Calcification occurs there. Chabi Thakkar, peroxisomal disorder should be there in the app. It is there as far as I know, but I will let you know. I will ask the team to check and I will post in the comments. For now, you can listen to the peroxisomal disorder video that I'm going to do. Okay, so let us start with. Then Aqua Thotum is asking changes after 1 week of galactose-free diet in a case of galactosemia. Aqua Thotum, that will depend upon the questions. Galactosemia also I will take up after this topic. So stay with me. So next topic is peroxisomal disorder. I will do a rapid fire quick review. Now, what are peroxisomes? You all know that peroxisomes are membrane-bound intracellular organelles. They are found in all cells of the body except mature RBC. Peroxisomes have enzymes for H2O2, hydrogen peroxide formation and degradation. Okay. They also have enzymes for membrane phospholipid formation. They also have enzymes for bile acid synthesis. So, and the peroxisomal enzymes also play a role in metabolism of very long chain fatty acid. We call them as VLCFAs. There is another group of disorder called as very long chain fatty acid disorder. That disorder and peroxisomal disorder tend to overlap with each other. So peroxisomal disorders are those disorders in which they are inborn error of metabolism, in which the number, function, or structure of peroxisome is altered. It is altered in the patient, right? Now, what are the types? Now, what are the types of peroxisomal disorder? There is a complicated classification given in Nelson 22nd edition. I will try to simplify it for you. They can be divided into two groups of disorders. The first group of disorders are called as the peroxisomal biogenesis defects. So we have PBDs. What are PBDs? We call them as peroxisome biogenesis defects. Peroxisome biogenesis defects. And the second category are called as single enzyme defects. Peroxisome biogenesis defects are those disorders where there are ghost peroxisomes. Peroxisomes either do not form or they are devoid of any enzyme. Whereas single enzyme defect will be milder and they will involve only a particular enzyme being deficient in the peroxisome. Peroxisome belong to a group of disorder called as Zellweger spectrum disorders. So Zellweger spectrum disorder, right? So they are also sometimes called as Zellweger spectrum disorder is written as ZSD. So their common name, another name of these disorders is PBD ZSD. What is PBD ZSD? Peroxisomal biogenesis defects as a part of Zellweger spectrum disorder. So what are the conditions included in this? You have three forms which are included. First of all, we have Zellweger syndrome, which is the most severe form of peroxisomal disorder. Second, you have a variety called as neonatal ALD, which is included here, Adrenoleukodystrophy. And thirdly, you have infantile Refsum disease. Remember that it is not an adult Refsum disease, it is infantile Refsum disease, which is being talked about. On the other hand, when we go to the single enzyme defects, these patients will include X-linked ALD. ALD, you all know the full form, adrenoleukodystrophy. It is a white matter disorder, involves adrenal gland, and it is a metabolic disorder. So it's, it is everywhere, X-linked ALD. Secondly, there is a variety called as Refsum disease. This is the true classic Refsum disease, also called as adult or classic Refsum disease. And third, there is a rare form called as acyl coenzyme A oxidase deficiency. Acyl coenzyme A oxidase deficiency. There are other subtypes also. When you read Nelson, you will come across another group of disorder called as rhizomelia punctata, and it has 5 types. But exams are around the corner. If you're having a bad day, really bad day, then you may get a question on rhizomelia dysplasia punctata. And trust me, it is highly unlikely anybody would be able to answer that. You need to understand that metabolic disorder is a multiverse of its own, right? It has so many disorders, right? So you should do them in moderation close to the exam. And so these are the important disorders mentioned, a part of classification. Some of the rarer ones I have omitted out. Now you can get one liner in the exam. If the examiner says which is the most common peroxisomal disorder, your answer will be X-linked ALD. But if they say which is the most severe, not compatible with life, child dies by 5 to 7 years, the answer will be Zellweger syndrome, right? So our focus of discussion will also be these two disorders. These 2 points you can add to your notes. Let us go. So let us start. And first of all, we will talk about the Zellweger spectrum disorder. Our focus will be on Zellweger syndrome. Zellweger syndrome. Now, patients of Zellweger syndrome, they are found to have Zellweger syndrome is found to be autosomal recessive in inheritance. Also, although some rare sporadic forms have also been described. Zellweger syndrome, it is not of one, it is a spectrum. And so you have PEX gene mutations responsible for Zellweger syndrome. PEX gene mutation lead to deficiency of proteins called as peroxins. So peroxins, which are a type of proteins, are deficient. Peroxins are involved in signal transduction of enzymes into peroxisomes. Let me explain in simple words. If you understand it now, when you read Nelson, it will be very easy for you. Think, peroxisome has enzymes, but peroxisome itself does not have, any own protein forming mechanism. It is dependent upon the proteins, the enzymes forming in the cytoplasm. So what happens is, you have the DNA, double-stranded strand, it opens up, coding strand forms mRNA, right? This process is transcription. Then that mRNA moves into cytoplasm, forms protein called as translation. Now proteins are nothing but many of them are enzymes. So peroxisomal enzymes also form. Now how this peroxisome enzyme will reach the peroxisome? The GPS system. Cell has its own GPS system, and those GPS systems, essential components are these peroxin proteins. You can remember that they are the GPS of the cell. They will guide these enzymes into the peroxisome. Now imagine a mutation happens. So what will happen? Enzymes will form, but they will not be able to reach peroxisome. And so many patients with Zellweger syndrome will end up having ghost peroxisome. Membrane-bound organelles, but no functional enzyme present. And so it is a severe disorder, generally not compatible with life. Within 5 years, the patient will die. And this, my dear friends, is also MCQ point. And I hope you now understand why Zellweger syndrome is most severe and why ghost peroxisomes happen, because no enzyme is able to reach because the transfer system is lacking in the patient. Understood? Now comes the cramming part. We have to cramify, we have to ratify, we have to just cram up the things. Zellweger syndrome, what are the key points to remember? First of all, these patients have craniofacial dysmorphism. So they have craniofacial dysmorphism. Craniofacial dysmorphism, they have a high forehead. Basically, high forehead means this hairline is going backwards, right? So receding of the hair, they're born with this. They have a flat face. Sometimes they can have the so-called slanting of the eye, similar to Down syndrome, although it is not a very classic feature. These patients can have ocular hypertelorism. What is hypertelorism? Increased gap between the two eyes. So medial canthi are wide apart, and these patients have hypotonia. And many of them are mistaken for Down syndrome as well. They are mistaken for Down syndrome. Second feature of Zellweger syndrome, they will have CNS dysfunction. This was the dysmorphism. So CNS dysfunction, they will have seizures, they will have developmental delay, they will have nystagmus. They will have nystagmus. Third, they will have hepatic involvement. They will have hepatitis. They can have cirrhosis. They can have hepatomegaly. They can have hepatomegaly. And fourth, they can have renal involvement in the form of recurrent cortical cyst. Because brain, hepatic, and renal is involved, Zellweger syndrome is also known as cerebrohepatorenal syndrome. So, which condition is also called as cerebrohepatorenal syndrome? It is Zellweger syndrome, which is known as, because as you can see in the photograph, as you can see in the notes which I have made, along with dysmorphism, CNS, hepatic, and renal involvement is always present in the patient. Now, what are the investigative clues? Investigation will show that there will be rise in the serum very long chain fatty acids. Why? Because very long chain fatty acid metabolism happens in enzymes of peroxisome, and peroxisome are ghost peroxisome, so they will be increased. There will be another test which is sometimes used as a screening test. So that is urinary pipecolic acid levels, which will be increased. And outcome in the patient is poor, treatment in the patient is supportive, and most of them die by 5 years of age. I know you will say कि sir Nelson तो कुछ और कह रहा है. I'm coming to that. 80% die in first year and 95% die by 3 to 5 years. This is mentioned in many review articles, and so this percentage you need to know. This is the disorder called as Zellweger syndrome, right? Zellweger syndrome. About the other two varieties, 2 and 3, they are found to be relatively milder one. Remember that neonatal ALD is the intermediate form. These patients will not have any facial dysmorphism. They will survive till about 10 years. They start in the newborn period. ALD means they will have some adrenal involvement also. So intermediate, and they will have adrenal dysfunction as well. So hypoglycemia due to low cortisol production will be there. And infantile Refsum disease will be relatively milder one, and they can survive into adulthood also, right? And Zellweger syndrome will die before 5 years. So these are the 3 forms: severe, intermediate, and milder among the PBD ZST disorders. Next, we come to the disorder you have been thinking about. Sir, kab karenge? That is X-linked ALD. X-linked ALD. I'm giving the heading X-linked ALD. As the name itself is saying, it is one of the most common peroxisomal disorder. Inheritance of these patients is X-linked recessive. X-linked recessive, and so only boys are affected. Only boys are affected. The gene of this patient is ABCD1 gene, which codes for a protein called as ALDP protein. This protein is involved in liver functioning, CNS functioning, and adrenal gland functioning, and so you will have manifestation of all these in the patient, but they will not be life-threatening. Patient can still lead a relatively patient will still not be, he will still be, the word is compatible with life. I will not say good quality of life, but I will say compatible with life. And in these patients, what is the characteristic feature? The characteristic feature will be elevation in saturated, very long chain fatty acids, because they cannot be broken down because of ALDP protein being absent. Especially, there is a protein called as hexaenoic acid, which is a C26 with C26 that is no double bond is present, but 26 carbon fatty acid, which is found to be elevated in the blood of these patients, because that cannot be broken down. So that is a characteristic feature. Now, what is the age of presentation? Most of these children present in the mid-childhood. So age of presentation is between 4 to 8 years. And what will be the presentation features? First of all, they will have CNS, I am writing like this. They will have CNS involvement. They will have progressive decline in scholastic performance. They will have increased risk of ADHD-like disorders. Some patients can have seizure onset also. Second, these patients will have vision and hearing abnormalities. Vision and hearing abnormalities will also occur. So vision defect will indicate due to occipital cortex dysfunction. So brain dysfunction are directly affecting the vision, and hearing abnormality can occur because of sensory neural hearing loss. And thirdly, these patients will have adrenal dysfunction. Remember that adrenal dysfunction is not the presentation and generally appears a few years after the CNS involvement has happened. So adrenal dysfunction will lead to CAH-like picture, but it will be more of a benign version of that. So there will be decreased cortisol, leading to during episodes of stress, patient can develop hypoglycemia. Although textbooks and articles have described about salt wasting crisis and some enzyme deficiency causing hormonal imbalance in the sex organs, that is rare. So it is predominantly hypoglycemic episode as a part of adrenal dysfunction, which is seen in these patients. And what is the investigation? When you do, you can do two things. You can do the blood investigation. So when you do blood investigation, you will find increase in the very long chain fatty acids in the blood and urine, in blood. MRI is of use here. When you do MRI brain, you will find that these patients will be having damage. You will find damage to white matter. You will find damage to white matter. Where the damage will happen? It will involve splenium of the corpus callosum. Remember that part of splenium which is connecting the two corpus callosum. So middle part of that, splenium of the corpus callosum. I'm writing like this, splenium of corpus callosum. It will involve periventricular regions, and it can involve cerebellum as well. So there will be progressive damage to white matter. And when you give contrast, so CE-MRI will lead to an appearance of garland appearance. So garland appearance is seen in patient of X-linked ALD when you give contrast to the patient. And what is the treatment that you are going to give? Treatment-wise, not much therapies are available that you will have to give. Eventually, see, bone marrow transplant is curative. Bone marrow transplant is curative, and you will have to give cortisol. Hydrocortisone supplementation will also be needed. Hydrocortisone will be needed for adrenal dysfunction. And these days, new gene therapies are also coming, but most of these gene therapies are not yet available in India. They are more of a historical perspective. And the new gene therapies available, including the gene therapy of this, a summary of all these new gene things, it is something that I have already discussed in the super specialty Nelson 22nd edition based updates in the PrepLadder SS app. So all of you who have access to that, please go through it once before you sit in the exam. If time permits, one of the LRRs, we can take a brief summary of that also. Right. So this is, but obviously details cannot be discussed and we don't know what is going to be asked. So it is always better to go with the proper videos, which are there on the PrepLadder SS app. And finally, few words of Refsum disease before we finish off and move into the next topic. So I'm giving the heading Refsum disease. Refsum disease. Refsum disease is a more of a less severe condition. So it has a chronic, progressive, adult version of peroxisomal disorder. So this is something where the patient can lead a relatively better life expectancy. I will not say quality of life, but better life expectancy can be there. And what is the gene which is involved in producing Refsum's disease? It is PHYH gene mutation. And the hallmark of these patients will be elevation in the levels of phytanic acid in the blood. So enzymes involved in phytanic acid degradation are absent in the peroxisome. So these are single gene defects, if you remember. So what will be the clinical features? These patients will have, first of all, demyelinating polyneuropathy. They have demyelinating polyneuropathy. Second, they have sensory neural hearing loss. Third, they have retinitis pigmentosa. So they will also have hearing problem. They will also have vision problems. Retinitis pigmentosa. They will have ataxia. It is cerebellar ataxia which is seen. Fifthly, these patients will have bony deformities. What are the bony deformities which can occur? There is a thing called as pes cavus. And these patients can have short fourth metacarpals or toes due to epiphyseal dysplasia as well. And treatment in the patient is basically restricted to Dietary phytanic acid restriction. Dietary phytanic acid restriction. What are the foods in which phytanic acid is found in high amounts? It is the fish and it is the dairy products where it is found more often. Some of the vegetables like uh, cauliflower and its American counterpart of that, broccoli, are also rich in phytanic acid. So phytanic acid containing foods need to be avoided. But generally the outcome, it is a very slowly progressive disease, and only in the mid or late adulthood, old age, you will have debilitating features really coming into play. So this is more of adult disease, so unlikely examiner will ask the details of this. This finishes our paroxysomal disorder. Beyond this, if we try to do, I don't think that will be justice to this live session like this. I'm opening the YouTube video again to see what comments you have posted, because I hope you are understanding whatever we are doing. Anudeep Venkat, Alexander Canavan. So see, they are not per se disorders, they metabolic disorders. They are more of leukodystrophies. So CNS disorder, I will be making a chart and I will be discussing that with you. So don't worry, that part will come, but not in this session. That will be coming in the future session. So CNS sessions, I will be trying to cover that. Okay, some of you have asked me about galactosemia. So let us discuss a few words of galactosemia. I'll do a rapid fire with you. So I'm giving the heading galactosemia. Galactosemia. More galactose in the blood, that is galactosemia, right? So galactosemia, what are the key points you should know? There are three critical enzymes. There are three critical enzymes involved in the breakdown of galactose. Whenever we take milk, milk has lactose. What is lactose? It's a disaccharide, combination of glucose with galactose, joined by a glycosidic bond. In our gut, there is an enzyme called as lactase that breaks it down into glucose and galactose. Now both come into the body. Glucose can be used directly. Galactose needs to be converted to glucose 1-phosphate, the usable form. And there are three critical enzymes. There are multiple enzymes, but three critical enzymes involved in the conversion of galactose into the usable product. What are these enzymes? I'm not writing in order, just the names I'm writing. We have the epimerase enzyme. We have galactokinase enzyme, also written as GalK enzyme. And we have GALT enzyme, also called as GalPut enzyme. What is the full form of GALT or GalPut? Galactose 1-phosphate uridyl transferase, also simply called as the transferase enzyme. Deficiency of any of these enzymes can cause theoretically galactosemia. If there is epimerase deficiency, that is considered to be the mildest type of galactosemia, also the rarest form. Galactokinase deficiency can also cause galactosemia, but it will cause only cataract, no hepatic damage, no renal damage will occur in the patient. And GALT or GalPut deficiency, the deficiency of this enzyme will cause what you call as classic galactosemia. So when we are talking about galactosemia, which variety are we talking about? The most common variety, that is classic galactosemia. It is most common also, and it is severe also. And so let us talk about the condition, that is classic galactosemia. I'm giving the heading classic galactosemia. Classic galactosemia, what is the type of inheritance? This also shows autosomal recessive inheritance. Insufficient GALT or GalPut enzyme, I have already told you. What happens in these patients? In these patients, there is inability to break down galactose into glucose 1-phosphate. So there is accumulation of two toxins. What are the two toxins? This is something indirectly, it has been asked in multiple entrance exams. Two toxins are galactitol, and second is galactose 1-phosphate, not glucose 1-phosphate, galactose 1-phosphate. Galactitol is the one which is responsible for formation of cataract in the eye. So which metabolite in galactosemia causes cataract formation? It is galactitol. And galactose 1-phosphate is the one which is found to be hepatotoxic, renotoxic, and neurotoxic. So systemic toxicity is produced by which metabolite? It is produced by galactose 1-phosphate. Okay, so accumulation of these two toxins is there. Let us talk about the clinical feature. Even if you have read galactosemia before, don't miss this point, because this is the point on which examiner puts questions. If you are running short on time, you have not read a metabolic disorder, I'm giving you a relatively foolproof way. There is no perfect foolproof way. Remember the name of the disease or alternative name. Most common enzyme deficiency, because you are doing last minute, so you can't do the rare variants, forget about them. Most common enzyme deficiency. Forget about chromosome number and gene also. Unlikely you will remember it, so don't read it, right? In metabolic disorder, I'm saying, if you have not read before. Number 3, what is the pathological hallmark? What is biochemical hallmark? Toxicity produce karne wala metabolite name. If such a metabolite name is there is a good chance examiner will ask it. Most common organ involvement, any drug of choice available or not. That's it. 6 or 7 points. Instead of leaving, you have a very good fighting chance. These are the areas examiners focus. But if you think sir ye karke kam chal jayega, this is not going to happen. So you need to read a bit more, right? So let us talk about the clinical features of galactosemia. So clinical features of galactosemia. Time of presentation. First of all, the time of presentation by the time these patients present is not in the day 1, it is not late, it is between day 3 to day 7 of life. So second half of first week is what Nelson also says. And many review articles say day 3 to day 7 of life. Because even if the child is taking milk, the galactose and its metabolites are getting accumulated, and it takes time for them to reach a certain critical level to produce toxicity. So of course, it is more of a viva thing. They can ask you, child takes milk today, he's just born, why doesn't he throw up and develop galactosemia? He can, but chances are it will take time for these toxic metabolites to accumulate, which varies between 40 to 72 hours, and then the manifestations will start. So in the first week of life, where a child who's consuming milk, mother's milk or cow's milk, buffalo's milk, wherever lactose containing milk is there, on taking milk taking child will develop a violent reaction in the form of vomiting. The child will develop decreased blood glucose, that is hypoglycemia. There will be jaundice. There will be hepatomegaly. There will be increased risk of developing E. coli sepsis. Escherichia coli growth is favored by undigested galactose circulating in the body. So which risk of sepsis is increased? E. coli sepsis risk is increased in the patient. Some patients can have raised transaminitis, that is AST and ALT also. And if you continue to give it by the end of the neonatal period, cataract will not form immediately, but cataract formation begins in the newborn period. By the end of the newborn period, the patient will develop cataract. What kind of cataract? It is oil drop cataract, which is seen. And this will interfere with vision. It is a central type of cataract, so that will affect the vision of the child. And the cataract occurs due to galactitol. That is something I have told you. Some patients can develop renal tubular damage. And if you continue to give milk, later they go on to develop delayed milestones also. And for survivors in later life, you will find that in case of females, there will be primary ovarian failure, that is leading to infertility found in almost all females. Now, people will say, sir, Q, we have restricted galactose in the diet. Why is the damage progressing? Because galactose is getting formed, galactose 1-phosphate is getting formed in endogenously also. Suppose someone does not consume milk. Does he not need galactose and galactose metabolites? He does. So how does the body generate that? The entire system, the enzymes are missing. And so endogenously formed galactose can also cause slow ongoing damage. And that is the problem in galactosemia. Restricting it fully will not lead to full recovery. Acute crisis will improve. Someone was asking me, sir, what happens? After about 1 week, the acute crisis will improve, jaundice will improve, transaminitis will improve. Cataract is reversible. Cataract will also improve, right? Cataract will reverse with time. If it is mature cataract, obviously you have to remove the cataract. But generally, if it is immature cataract, cataract will also improve. However, CNS damage will progress, infertility will progress, renal damage will progress. It is the liver damage which is kind of reversible if you stop external exogenous lactose in the patient. Okay, I hope the funda is clear. Investigation wise, there is a screening test. It is not done these days, but still, when examiner puts questions, they will be putting on this. So you will do a test called as urinary Benedict's test. And urinary Benedict test will be positive for non-glucose reducing substances in urine. And what is the investigation of choice? Now you can always go for the enzyme activity. You will check for GALT enzyme activity in the blood. GALT enzyme activity in the blood. And treatment in the patient, the only treatment available is avoid lactose containing in the food, in the diet. So lactose, because lactose is the one which is going to give galactose, and these patients need to be followed up for a long duration as well. So these are the points related to galactosemia that you need to remember. And then somebody was asking me about maple syrup urine disease. It's already 8:20, so I will not take much of your time. I will rapidly hasten up. I will increase the speed. So last thing, let me have a look at the chat box. What are you people posting? Whether you are understanding or not. Thank you so much. Good evening for those who are joining right now. It's a rapid revision kind of thing we are doing. I'm only selecting those things which have been asked in the recent exams in NEET SS and IEM SS. My purpose is not to train you for your university papers. We are only discussing topics. My focus is on high-yielding things. And next we come to the disorder called as maple syrup urine disease. You need to understand that maple syrup urine disease is a disorder which is a broader part of organic acidemias. MSUD is a type of organic acidemia, but it's a disorder which is fairly prevalent and often asked as a standalone topic also. MSUD, maple syrup urine disease. If you are running short on time and you want to be sure and not leave a topic, NEET SS, I will tell you the years it has been asked. NEET SS 2018 it has been asked, 2021 it has been asked, 2022 it has been asked, and it has been asked in INI SS also 2 times. So I am sure you will read this topic properly. Summary video, obviously longer than what I am discussing here, is posted in PrepLadder Super Speciality Rapid Revision section. It is already done. So I have not opened the app since few days, but I got I saw the video, the edited version. I gave the go ahead. It should have been there by Hodi. So go through it once. Still, even if you're not reading that, please go through the Nelson part of MSUD. What is MSUD? MSUD stands for maple syrup urine disease. Maple syrup urine disease. What is the type of inheritance? These patients are having autosomal recessive inheritance. So what kind of inheritance is seen? You will find autosomal recessive inheritance. What is the enzyme deficiency found in the patient? The enzyme deficiency is BCKDH enzyme. What is BCKDH? Full form is branched chain alpha keto acid dehydrogenase. This is the enzyme which is found to be deficient. Branch chain alpha keto acid dehydrogenase is normally involved in the metabolism of branch chain amino acids. This is normally involved in breakdown of branch chain amino acid. So deficiency of BCKDH will lead to inability to break down branch chain amino acids. BCA is branch chain amino acids. So 3 amino acids will accumulate. You have VIL as the mnemonic. VIL. Valine, isoleucine, and leucine. And it is the leucine among them which is found to be maximum toxic to the patient, producing most of the manifestations. So what is maple syrup urine disease? Branch chain alpha keto acid dehydrogenase deficiency. These amino acids come in the diet, but there is a way to catabolize them if the excess happens. If this enzyme is deficient, the body will not be able to break down these amino acid. Three branch chain amino acid will accumulate: valine, leucine, isoleucine. Among them, leucine is the one which is neurotoxic, and this neurotoxic agent is going to cause most of the manifestation. This is your maple syrup urine disease. So what are the clinical manifestations? So I'm giving the heading clinical manifestation. These patients, first of all, CNS damage. CNS damage occurs because of which? As amino acid, leucine. What happens is, leucine, when it is in excess, it enters, in excess leucine enters the blood-brain barrier. It crosses the blood-brain barrier, enters inside the brain, and there it gets converted into its toxic metabolites like alpha ketocaproic acid, also called as alpha keto acid derivatives. Alpha keto acid derivatives. These alpha keto acid derivatives are the ones which cause oxidant damage to the neurons. They produce free radical damage, and they also disturb the balance. They produce imbalance between neurotransmitters, leading to neurotoxicity. Think of it like this, that leucine is the godfather, the gangster who advises hit job in the brain, and alpha ketocaproic acid or alpha keto acid derivative is the assassin, the hitman, who actually carries out the assassination inside the brain. Right? So this is how the CNS damage happens. So what are the manifestations which will happen? First of all, the child will develop tone abnormalities, so dystonia. Child will have seizures. Child will have apnea. And there is a very unique thing. The child will show the so-called cycling and boxing movements. Why cycling and boxing movements? This happens. This is a very unique thing because there is alternate hypo and hypertonia happening in upper and lower limbs, particularly during the acute phase of the disease. So some child lying, then tone will increase, then tone will fall. The tone will increase, tone will fall. Boxing movement. Sometimes both sides of the body, alternately it will happen. So boxing movement. Similar thing happening in the lower limb, as if the child is cycling movement. This is very specifically described. It can occur in other organic acidemias also, but it is very clear and clue for underlying maple syrup urinary disease. So CNS damage, and because CNS damage happens because of leucine, it is also called as leucinosis. Damage to the brain caused by leucine. We call it as leucinosis. This is the first problem which will occur. And these patients can go on to develop opisthotonous posturing, decorticate, decerebrate posturing, and even death can occur sometimes. Secondly, these patients will have other problems. These patients will have abnormal urine odor. And what is the abnormal urine odor? Maple syrup urine odor, also called as burnt sugar syrup like urine odor. Rarely, some patients can have some hepatic manifestations, although they are not very significant as a cause of death in these patients. Now, what is the investigations that you will do? Investigations will reveal that there is increase in the blood levels and urinary excretion of branch chain amino acids like valine, leucine, isoleucine. There is also increase in the blood levels of allo-isoleucine. Remember, allo-isoleucine, according to Nelson, it is the most sensitive and specific test which can be done for if enzyme analysis is not available. Allo-isoleucine is not found in you and me. Normal people don't have it. If you find it and the levels are high, that indicates branch chain keto acid dehydrogenase deficiency. So it is a derivative formed when the proper metabolism of isoleucine cannot happen. So increased blood allo-isoleucine level. And there is an older test we used to do called as urine test for 2,4-dinitrophenylhydrazine, which used to give yellow precipitate in the patient, which was considered to be a positive test. But it has low sensitivity and specificity, so it is not done these days, but it can still be asked in the exam. And what is the treatment that you will give in the patient of maple syrup urine disease? First of all, any acute illness child, you need to rapidly clear leucine from the body, because longer leucine circulates, more damage it is going to happen. Hemodialysis is the fastest way to remove leucine from the body, and many times the initial CNS damage can partially reverse as well. So acute hemodialysis should be done. Then these patients you will be starting as a maintenance therapy. Maintenance therapy you will give low leucine diet, but you should avoid totally restricting. You should avoid totally restricting valine and isoleucine. So you allow them, basically you allow them in the diet. Why? People have tried restricting all the three branch chain amino acid thinking it will benefit. No, actually what is happening is, think of it like this. I told you leucine is a gangster. It is a gangster not only for the body, it is a gangster for his two brothers also. Valine and isoleucine are members of the same family, but think of it like that gangster always bullies his two younger brothers. And so he does not allow them to enter into the body, into the tissues as well. So in fact, it is seen that if you restrict every branch in amino acid, patient develops, Nelson says, acrodermatitis enteropathica like illness, and patient actually becomes more sick. So what we do is, within limits, some valine and isoleucine is given. How it helps? It allows the toxicity produced by the absence of these amino acid plus valine isoleucine will compete with leucine and reduce its absorption in the diet. It will reduce its entry into the tissues and particularly the brain, right? So basically what we are doing is, if we can't directly target the gangster, we are propping up people in his family. Think of leucine as Raman, and valine and isoleucine are forms of Vibhishan. So we are Ghar ka bhedi lang kadha hai. So we are putting valine and isoleucine and putting it up, using it to counteract the effects of leucine in the patient, right? So this is, I know very stupid examples I'm giving, but if you read Nelson and if you understand, it actually makes sense. And so you should not do complete restriction. If there is an option asking you that they should be totally restricted, the answer is no, they should not be totally restricted. Okay. And apart from that, what you can do, many patients will not respond to these or they will present late. So advanced cases, if they present, then liver transplantation is the only therapy that can save the life of the patient. Liver transplantation. And finally, some patients of MSUD, they have thiamine responsive. They have thiamine responsive MSUD. So we always give a trial of thiamine. We always give a trial of thiamine in these patients. And sometimes some patients tend to improve. So we give a trial of these patients, this drug as well. So this is regarding maple syrup urine disease, high yielding topic. So I've tried to cover the maximum points I could. I'm also getting the message from the team that the session duration is now over. I would love to teach you more, but again, the time is never full. And I will make sure that if there is any of the videos which are not uploaded, for those who are subscribers of Pediatrics Super Speciality, you will have a rapid revision session of metabolic disorders, including all this in slightly more details, of course, than what we have discussed here, coming up on the app. I have already approved them, so just a matter of time. Long weekend and Holi was there, so they should be appearing anytime on the app. So go through that, and end of the day, Nelson, you need to go through. We have not discussed few words regarding heart nerve disease. We have not discussed few words regarding glycogen storage disorders. Both of them, along with some of the systemic parts and syndromes, I will be taking in the LRR session part 3. LRR session is coming soon. The details are already there. And for this, the video of this particular section, it will be made available soon in the comments section, right? So that's it. So Chabi Thakkar, in case you are active on my Telegram group, you can message there. Or after this video goes up, you please post in the comment again. So I will be sending a detailed reply to you at that time. Okay. Thank you so much for hearing and listening to me. And let's meet again. Metabolic disorders should be done in moderation. When done in moderation, they are great for your scores. Thank you so much. Bye-bye.